Welcome to Healthy Frontiers. My name is Dr. Bizzoni. I'm a chiropractor, and this show is dedicated to the education of our viewers. The topic for tonight is scoliosis, and my special guest is Dr. Baron Lonner, MD. Dr. Lonner is a professor of orthopedic surgery at Mount Sinai Hospital in New York City. His clinical interests are centered around the operative and non-operative care of the patient with scoliosis and other spinal deformities. He has performed over 3,000 surgeries in pediatric and adult scoliosis patients, including primary and revision surgeries. Dr. Lonner has been an innovator in the area of minimally invasive surgery of the spine for scoliosis, kyphosis, and other conditions. His approach to patients and their families is a holistic one, in which the patient's quality of life is at the forefront of decision-making. Dr. Lonner has over 120 publications in the orthopedic literature. His research interests include outcomes in spinal deformity surgery and non-operative care. He and his team have developed 2 new outcome instruments for adolescent idiopathic scoliosis. Dr. Lonner has a keen interest in the interplay of cost and quality and the value equation in spine care. Dr. Lonner is a board member of Scoliosis Research Society. He has traveled extensively, performing operations in developing countries on children with severe spinal deformities in Africa, the Middle East, and the Caribbean. He's a consultant for Dupy Synthes and Johnson & Johnson companies, and is one of the developers of the Expedium spinal implant system used in the treatment of scoliosis and other spinal deformities. So I'd like to welcome Doc to the show.
Thank you, Lou. It's good to be here.
Good to have you here, Doc. Doc, we're going to get right into it. You know, I just gave a nice little introduction here, and we use a lot of words that the audience may not understand. So why don't we start off with something? What is scoliosis?
Well, Lou, scoliosis is a curvature of the spine. But it's more than that. It's a side curve or a lateral curve, but it's really a 3-dimensional deformity. It's a twist and a rotation of the spine as well, and it manifests itself in the patient's body shape. They have asymmetries in their shape. For example, their waistline may be off. You can see differences in one side to the next. Their shoulders may be uneven, their waistline uneven, and then they often will have prominences or humps on their back.
Right.
Hump is a bad word, but it's really a twist and a bump on their back that comes as a result of it. And if I take this spinal model, you can see here's a straight spine, and we're looking at it from the back, and these are the spinous processes. And the patient will typically, for the most common type of scoliosis, they'll have a right-sided curve like this. But not only is it curved, it rotates. And with that rotation, the ribs are attached here, they stick out. So it's a 3-dimensional deformity.
Great. Okay, so patient walks in your office, they already may know that they have these curvature problems.
Yes.
And then you go on and evaluate from there.
So patients come in a number of different ways. Either a family member, I treat both pediatric and children and adolescents and adult patients. And so the mom or dad may pick this up, or a friend at school may notice when they're in their bathing suit, or at the pediatrician's office. The adults usually know that they've had scoliosis for many years and decades in some cases, and they present with pain.
Right, and it's so important, isn't it? Isn't it a law now in New York State that they have to have an evaluation in school for scoliosis?
So there are a number of states that have school screening mandated. New York is one of them. Unfortunately, in the boroughs around the Manhattan and the other outer boroughs, there's an exemption, so the kids don't get screened in school. But in White Plains, for example, I believe there is school screening here. And so the kids get picked up, and often they have very mild curves, which is great, because we have an early detection, which is really the key to treatment. If we can treat them without surgery by picking the curves up early, that's really very beneficial. We can treat them with exercise, scoliosis-specific exercise therapy. There are different methods. Some chiropractors are involved, physical therapists. They do the Schroff method. And bracing is another option for kids. For adults, there are other options which we can speak about.
Good. We're going to get into that a little bit later, a little more specific on that. But what does it affect? And are the different types of scoliosis?
So there are the main type, the most common type, is idiopathic. Basically implies that we don't know what is the cause, but we do know it's a genetic type of form of scoliosis that runs in families. So For the vast majority of the adolescent patients that present to us, 80% of them have idiopathic scoliosis. It's kind of the good type, if you will, because there's no underlying condition. They have this curve, they're otherwise completely healthy, but they happen to have scoliosis. And other types include congenital, meaning the vertebrae or the building blocks of the spine are misshapen at birth. So in the uterus, they did not develop properly. There may be half of a vertebra. We call that a hemivertebra or fused vertebra. And because of that, with growth, the spine grows crooked instead of straight. So they develop a scoliosis. Or in some cases, they might develop kyphosis or rounding of their back. And so some of those patients have very severe deformities and curvatures that need to be treated when they're much younger in age. The adult patients present either with idiopathic scoliosis that was either picked up or was missed when they were in their adolescent years, but they delayed treatment. They didn't have treatment until they present with pain and disability in their adult years. And so there's a whole laundry list of causes of scoliosis, but again, the main one would be idiopathic. In the adults, though, as we look at adult individuals throughout their lifespan, when you look at adults in their third decade, in their 20s and 30s, you see that very few of them have scoliosis. But as you get into the 60s and 70s and 80s, many of those patients, up to 60%, will have some degree of what we call degenerative or wear and tear scoliosis from wedging of individual discs, and it causes a local scoliosis and deformity. So you can see, if you look at older people, many of them will have a subtle twist or curve, and that's a different form of scoliosis.
Just let's let the audience understand the difference between scoliosis and kyphosis.
Well, scoliosis is much more common, at least in the child and adolescent. Scoliosis is a side curve. Kyphosis, or rounding of the back, and we all have a certain degree of kyphosis that is normal, but when it's excessive, we call it a problem. And so for many kids that present, they just have a poor posture, and so they're rounded that way, and we give them exercises to address that. But others have a stiff structural form of kyphosis that doesn't easily correct. And there are different forms of those that sometimes need surgery or bracing. And when we look at adults, everything sort of goes downhill gradually for us all as we go through life. But adults tend to round and become more and more kyphotic or rounded as they get older. And that's sort of the natural progression of aging that we all go through.
Which we might see our old grannies as kind of hunched over.
Exactly. Exactly. I'm sure you see a lot of that in your practice.
We see a ton.
Yes.
Do patients have pain with the scoliosis?
The younger patients don't. Well, it's not exactly true. That we teach our residents, or in the old days taught our residents, that adolescent scoliosis is not painful. Some of them, and many of them, have some fatigue and strain of the muscle, a feeling of discomfort usually, and sometimes it affects their activities. But generally doesn't impact their ability to do the things they want to do, including sports. It's as the patients get older into their adult years and over time that they develop pain, and more pain as they get older. And so the adult patients that I see, and I'm sure you see, are more disabled from their scoliosis. And there are different causes of that pain. For the adolescent, for example, their pain is generally because the muscle is stretched over the longer side of the spine, over the curved portion, and so the muscles are fatigue easily. And they may have more pain at the end of the day or after an activity. As we get older, the adult patients have other sources of pain. The joints become arthritic, so arthritis can be a cause of pain. They may have compression or pinching of a nerve, which can cause pain that shoots around their chest or down their leg, sciatica. Or another cause of pain in severe adult scoliosis is the rib impinging on the pelvis, and that's very painful and very common.
Got it. Good. Great. So do treatments differ for children and adolescents, versus adults?
Yes. Well, the standard... Well, first we'd like to consider non-surgical treatment for all of our patients, and that is guided largely, especially for the growing child, by how severe the curve is. So if they have a large curve, usually we will recommend surgery. But if the curve is not too large, under 40 degrees, we may recommend a brace. And the purpose of a brace is to halt progression, to keep the curve from getting worse. Sure. And nowadays we've been offering as well scoliosis-specific exercise therapy that I mentioned earlier, Schroff technique or other techniques.
Sure.
And so that's an offering. And for our adult patients, we'll generally give them an exercise program, physical therapy.
Right.
They may take an anti-inflammatory and non-steroidal, such as ibuprofen. And again, the conditioning and exercise is very important.
Right.
Also for the adults, and they may see chiropractors often as well.
Yes.
Often for the adults, we'll send them for pain management where they may get injections into those arthritic joints or an epidural steroid injection, which is to bathe the nerves and deal with any sciatica they may have.
Great.
Finally, for both the adult patient and the pediatric patient that meet the criteria, then surgery is offered. So if a child has a progressive curvature or a curvature of more than 40 degrees to 50 degrees, then we'll often go straight to a surgical recommendation.
Right.
And the standard of care for surgery has really become a spinal fusion, where we do that from the back of the spine. So, and the same holds true for the adult patients. So we'll put screws, multiple screws and metal rods into the spine. We'll loosen up the spine by cutting into the bones, and then we'll straighten it out.
Right.
And we typically get a much better correction in kids than we do in adults, particularly the adults who are older and have larger curves.
Right.
So when we compare surgery, the standard fusion surgery for the adult versus the adolescent patient, and I'm going to be giving a talk on that in Prague in a few weeks.
Nice.
We see that the length of surgery is much longer for the adult. The number of levels that we fuse of the spine is substantially greater. The blood loss is greater, and the complication rates are higher. So adults have a very high complication rate compared to kids. So we offer these families counseling on what does surgery look like now versus what it might look like as an adult. So that gives them another piece of information to use in making decisions. Now, there is a newer option now for kids and young adults, and that is called tethering or flexible fusion operation.
Right.
And we have been fortunate to be involved in that. It's only a few years old in terms of the technique, but I've had extensive experience doing these approaches where we go through the side and we place screws into the vertebra or the building blocks of the spine. And I can show here what that looks like. So these are the discs or the shock absorbers of each level, and these are the vertebra or the building blocks of the spine. And so what we do is we place a screw that goes in through the vertebra to the other side, so through and through. And instead, in the past, when we were doing fusions through this approach, we would remove the discs, put bone graft in there, and use a metal rod. Now we use what we call a flexible cord rod. It's really kind of like a bungee cord, and it allows us to compress down at each level and get correction. But it preserves motion, flexibility, function for the patient, and it allows them to grow as well.
Yeah, because that's always been a concern, I think, for a lot of people. If I get the surgery, I'm not going to be able to move. They're very inflexible.
Right. And so it turns out for the adolescents that we've done fusions on, and we've looked at this, they maintain their flexibility and motion, but of course they don't do it through the fused segments. They're doing it below and above. And so it puts extra stress, additional loads and stresses on the remaining discs, and therefore they may be at risk for breaking down sooner.
Sure.
So I think this offers a wonderful option for those patients who meet the criteria.
And that's great. I know you're on the forefront of this new tethering technique, and that's terrific.
It's very exciting.
Yeah. Doc, let's go back a little bit before the surgery again.
Yes.
Are x-rays always required, and are there any new ways of diagnosing and following scoliosis?
So when we first evaluate the patient, we'll do an x-ray. That's the best way we have to really diagnose and to see the individual vertebrae and to actually measure a curve. So we do use an x-ray as a starter, but for kids who are growing and we're going to be observing them over time and following them to see if they'll be progression, and as well for adult patients.
Right.
Once we have that baseline x-ray, we can now use a new technique, a new modality called, I call it Scoliscan.
Okay.
It's Deers Formetrics is the system, and it shines light on the patient's back, and we can look at their front as well, and gives us a surface topographical map of their back in 3 dimensions.
Nice.
So it's a very powerful tool, and it's very accurate. We've done studies to prove that it's a reproducible technique. And so if there are no changes over time, there's no need to get an x-ray.
Right.
If we see a change, then we'll likely do a repeat
Right.
x-ray to
Sure.
actually measure an angle.
Well, that's great,
So-
and hopefully will prevent taking too much radiation, etc.
Exactly.
Right. So are there any special or new non-surgical treatment options that you're familiar with now?
So there are changes. We know that bracing is very effective for those kids who meet the criteria, who have a progressive curve that's over 20 degrees
Right.
and whom growth remains. So for them, we know that bracing is effective in halting curve progression or worsening.
Right.
And there's been a recent NIH study that showed that. So there are different types of braces. Now there are lighter braces with thinner material, with computer-generated images of the patients, and then the plastic model is made from those computer-generated images. So it's a very precise, molds nicely to the patient with thinner and lighter plastic. So that's one really exciting area, and I think patients really appreciate that. Nobody really likes a brace.
Right.
Yes.
Right. Especially the kid.
The kids,
You know, they really
don't.
Yeah. Right.
So, and then there's this Schroth exercise therapy, and there's the CLEAR method. I know the number of chiropractors are working with, and I think they spend a lot of time with patients and really work on exercising them and giving them flexibility and some correction potentially of their curves.
Right. Right. So anything you can do before it gets to that 40-degree
Exactly.
mark.
Yeah, we're all for it.
That's it. So what are the surgical options for children and adolescents?
Right. So in the common approach for surgery, the technique has really been spinal fusion.
Right.
And we can do that through the side, as I illustrated a moment ago. Instead of using the flexible cord, we can put metal rods in, and we correct the curves very nicely. And the patients generally do very well for decades and decades.
Right.
But of course, that's a spinal fusion. So if we have a way of correcting the curve and holding it, maintaining that correction for years and decades ideally, and preserving their motion and flexibility, that's ideal. And so that's this new exciting vertebral body tethering, VBT we call it, or a flexible fusion procedure. And so that, I think, is going to revolutionize the treatment of patients around the world. And right now, there are only a handful of surgeons around the country who are doing these, using these techniques. But I can see that my practice is growing in that area because patients really seek that out.
Yeah.
Now, it's not FDA approved yet for this indication. It's an FDA-approved device that we use, but not for this.
Right.
But we explain that to patients and give them the options, and their families are often very enthusiastic about this technique.
Yeah, I mean, it sounds terrific. I mean, flexibility is so key. Wow.
Yes.
So how do you maintain safety and quality in scoliosis surgery?
Right. So really, when families come to us, either for their child or for their husband or wife, they really want to know that they're going to be well cared for and that their surgery will go off safely and that they won't have a complication or a problem. So we spend much of our time and our thinking on how do we minimize complications, how do we maximize the patient's experience and their outcome and their satisfaction. After all, that's what it's all about.
For sure.
So we have protocols in the hospital. We have meetings on quality and safety in the hospital on 6 a.m. and early mornings. But we also, in surgery, during the surgery, we have a 2-surgeon team, and that's been shown to decrease the operative time, it decreases blood loss, it decreases reoperation rates, and improves outcomes, basically, so lower complications. So that's another thing we do. We use spinal cord monitoring and nerve monitoring to ensure that the nerves and spinal cord are protected during our procedures.
Yeah.
With bigger curves, they can be higher risk, and so we need that constant feedback to know that the patient's nerve structures are functioning fine. We use a special suction called Cell Saver to capture their blood during surgery. We filter it, wash it, and give it back to the patient during surgery. So minimizing the patient's exposure to blood bank.
Right.
We control their blood pressure. We give them special medication called TXA, also to decrease their bleeding.
Yeah.
We lower infection rates by having the two-surgeon team to make surgery more efficient, less bleeding, which also can be associated with infection.
Yeah.
And we have a plastic surgeon close, so I think that helps cut down on incision problems and wound problems that some patients can experience. So we do many things to really improve upon our results, and we're constantly looking for better ways to do so.
Yeah. Well, those are great things right there. So you have two orthopedic surgeons, or a neurosurgeon, orthopedic, whatever's necessary?
Both, yes.
Both,
yeah,
right
we'll
there.
often have a neurosurgeon or an orthopedic surgeon, depending on the nature of the surgery.
Great. So how do you determine if a patient's had a great outcome from their surgery?
Right. That's a great question. You know, one thing is usually the patients will come in and they're smiling.
Yes.
And they give you a hug when they see you, or the mom gives you a hug if it's their child. And so that's one way of knowing. But we we listen to them. Have they returned to their activities? Are they content with their activity level? Is their pain controlled? Is their pain improved? Is it gone? We look at an X-ray, so we can see a very dramatic before and after picture showing a curved spine and then a beautifully straightened spine, and we look at that, and we then examine the patient, and we see that those bumps on their back, the rotational prominences or the humps, have improved, and they often dramatically improve. And we can use that surface topography that I talked about, Scoliosis, and that shows how the body surface, the body shape has dramatically improved. And then I think even more important than all of those things, we have various questionnaires that we give the patients, and we've developed 2 new questionnaires that we think hopefully speaks to what the patient is concerned about. One is the body image disturbance.
Right.
I don't like the way my body looks. It affects my activities. It affects my social interactions. And then another one is called TASK, Truncal Anterior Asymmetry Scoliosis Questionnaire. It's a big name. But basically it's about the frontal appearance, the front of the patient, what they see in the mirror. The rib sticks out here. One breast may be longer or shorter than the other, or sticks out more than the other. How will that change? And so we're starting to understand a little bit more about the front appearance of the patient and what it means to them before and after surgery. And I think probably the most interesting area that we're working on now, which I think is the holy grail of understanding a patient's outcomes, is really specific to the patient. It's not a doctor-generated questionnaire. This is one that the patient develops, essentially. It's called the Patient-Generated Index, PGI. What does that mean? The patient picks 5 areas of their life that are affected by scoliosis. I can't play ball the way I'd like to because my back hurts when I throw, or I don't like the way my back looks in my regular clothes or in my swimsuit. Or my work is affected, et cetera, et cetera. So the patients pick 5 items that are affected by their scoliosis. It may be breathing. I'm having trouble breathing. It's not what I'd like it to be. I get winded very easily. And then they rank those areas. They weight it. So this is the most important, this is the least important, and this is the percentage of importance that it has. And then after surgery, they take their own questionnaire again and see how well, we all see how well they fared. And we can do that over time. And then they can change the priorities as well. They may say that what was important to them before surgery now is less important, and now something else is important. So that's going to be a whole future area of study going forward for us.
That's great. So what do you see for the future of scoliosis care?
I think the future really is going to be in this non-fusion surgery. I'm hoping that we can develop these techniques so that some adults are amenable to them. I think certainly the young adults will be good candidates as long as their discs have not degenerated or worn out. Because if they have worn discs, they can be painful. And so maintaining motion within a painful disc is probably not a good idea. But for those who have healthy appearing discs and have good flexibility and not pain related to the disc, I think we can use this non-fusion approach, the tether, for those patients, and certainly for the kids. And I see that more and more of our pediatric patients are going to be treated without a fusion. And I think there'll be other techniques that are maybe done from the back, so it'll be more familiar to other surgeons who don't have the experience going through the side. I think we'll develop techniques from the back in which motion will be preserved, and maybe we'll get away from bracing at some point. Maybe there'll be some less invasive operations that allow patients to have a correction that it's reliable with low risk operation, but can avoid the use of a brace, because braces are not perfect for everybody. They're very difficult. It requires a commitment of the family, of the patient, of the child, to wear the brace at least 16 hours per day in most cases. And it can be difficult for some of the adolescents.
For sure.
Yeah.
So just before we end, Doc, why don't you just tell the audience a couple of things they can look out for in their children to maybe just give them some idea that something may be happening.
Yes.
Okay.
So I think one thing is to just look at them while they're standing. If one shoulder's up compared to the other, if their waistline is uneven, there may be an indentation in one hip and it'll be straighter on the other. Their body may be shifted over to the left or to the right. And you can even have them bend forward, having their legs, their knees straight, and they bend straight over and let their arms hang down below them, and you can sight right down their back. And if there's any asymmetry one side versus the other, that's a sign maybe that there is scoliosis. And that's probably the time when you should take your son or daughter to see a specialist.
For sure. Would they see their pediatrician first, or can they come right to you?
They could come right to me, or they could go to the pediatrician. I think if there's any question, they should come to a specialist and have an x-ray done and be evaluated.
I agree.
Yes.
Great. Doc, well, it was a pleasure to have you on the show. Thank you so much. And I want to thank Dr. Lonner for being such a wonderful guest, and we look forward to seeing you on the next show. Thank you.